where you are. Thank you very much to the conference organizers for inviting me to present today. I'm very excited to be here. My presentation is Shedding Light on Endometriosis, Patient and Provider Perspectives on a Challenging Disease. I'm going to go ahead and get started. I don't have any relationships to disclose. I am a researcher and scientist at Thomas Jefferson University, which is located in Philadelphia in the United States of America. My acknowledgements, I want to acknowledge the rest of my research team at the College of Population Health. And go ahead and get started. So what is endometriosis? For those of you who don't know, endometriosis is the presence of endometrial-like tissue found outside of the uterus. That distinction is very important to know because a lot of times still in the literature and when talking about and discussing with providers, endometriosis is often misdefined as the presence of endometrial tissue in the uterus, and that is not correct. It is a hormone-dependent inflammatory disease. It's characterized by pain and infertility most commonly. A lot of symptoms present as urinary or GI symptoms, painful sex, and other symptoms like fatigue and pain in other parts of the body. It is one of the most prevalent diseases in gynecologic practice. It affects an estimated 1 in 10 or upwards of about 200 million people worldwide. There is no known cause for it, which is one of the problems in trying to diagnose it. Schools of thought think that it could be retrograde menstruation, which is probably the oldest theory regarding this disease, as well as genetic and or autoimmune. There is no way to test for it. So the only way to diagnose this disease is surgical diagnosis, and that's typically done laparoscopy, and can be done by ablation or excision in order to remove the disease. There is a latent diagnosis period, which is typically anywhere from 7 to 10 years on average from symptom onset. So when someone first experiences pain and symptoms with their menses, until they get an official diagnosis via surgical and pathological confirmation. There are limited treatment options. The first line treatment is typically hormonal birth control, whether in the form of oral birth control pills or IUD. Surgery really is the gold standard, and excision is the gold standard in order to remove the disease. Unfortunately, though, there is no cure for this disease as it is recurrent. So even though if you have the disease removed by excising it via surgery, it does recur because it is hormone dependent, which is an important distinction to make. So that's just a little bit of information about what endometriosis is. What we know, endometriosis is a public health problem. There's a burden to the individuals who have this disease. And typically, yes, most individuals who have endometriosis are individuals with uteruses, but trans, non-binary, and gender non-conforming individuals also can have endometriosis, which is something that adds to the stigma with this disease. The burden of the disease continues to grow. It's economically not coherent to continue to have surgery for a disease like this. Typically, on average, most people with endometriosis have anywhere from 1 to multiple, surgeries up towards 10 surgeries in order to over the lifetime of the disease. And that's not economically coherent or sustainable for the healthcare system, regardless of what country you are in. And many of the aspects of the disease continue to remain misunderstood and require further exploration. And as I mentioned, there's no cure, there's no way to diagnose it other than surgery, and there's no, right now, the literature does not point to why this disease occurs. So what our research studies serve to do is shed light on provider understanding and behavior on the patient experience, because oftentimes there are two juxtapositions from the provider and the patient standpoint. So here we have our study aims, provider perception, then patient experience, and then the analysis and the interpretation of our mixed method study. So we wanted to look at what do providers know, and then what do they actually say? And the patient experiences, what have patients experienced with this disease over the course of their lifetime? And then we wanted to identify key components and gaps in current practice in order to improve outcomes and coordinate care. So provider recruitment looked at a number of providers across multi-specialties, including OBGYN, primary care, family medicine, internal medicine, GI, and then other specialties, including radiology as well. The main question we looked at, the survey that we used, was a 10-item questionnaire, with the main question being, what is the prevalence of endometriosis in women of childbearing age? And we had multiple choice answers. And while the correct answer is 1 in 10, when we went to query our providers, which again were across multiple different specialties, we saw that the results were less than or just about 11% that individuals who responded to the survey got the correct response, which is, again, it's about 1 in 10 individuals who have endometriosis. And we all quantitative analysis were conducted using SPSS, and we were able to kind of look at and distribute the question that we were looking at, the endometriosis prevalence question, with what their specialty was, how long they'd been in practice, how much time they spend in patient care, what their licensure was, whether they're a physician or a nurse practitioner, et cetera, as well as some other demographic information. But the main thing we were looking at was to determine what individuals who were providing care to individuals with endometriosis, what they believed the correct prevalence of endometriosis to be. We then followed up with some of those providers who answered the survey to see what they say. That was our second part of our aim, what they know and then what they say. And a lot of the qualitative data that is kind of expressed here in this chart just talks about the limited training and difficult diagnosis that endometriosis is. And this is something that individuals, patients with endometriosis, and providers, no matter what specialty they are, and whether they're OBGYN, gastroenterology, primary care, et cetera, speak about the difficulty of the diagnosis. And I think a lot of it comes from the fact that medical school and training doesn't have a more robust curriculum with regard to reproductive health curriculum. And reproductive health curriculum is quite large and covers a lot of areas, but endometriosis in and of itself is really not covered in any extensive manner. And so that was one theme. Another theme that the providers, and then again, the providers came from OBGYN, gastroenterology, radiology, and primary care, is that they don't necessarily have the tools to treat or adequately manage someone with endometriosis due to the complex nature of the disease. It presents often as unspecific abdominal pain. And so if someone's presenting to their primary care doctor at a age where maybe they're experiencing their first menses, or trying to get pregnant or something like that, they are kind of run through the gamut of what this could be. And if they're getting imaging done, endometriosis is microscopic in nature. And so oftentimes, unless there's an endometrioma, which is a chocolate cyst, more or less is how it presents. Unless that is present, you're not going to be able to detect the disease with imaging, whether it's ultrasound, MRI, or CT scan. So again, that puts us in the quandary of only using surgical laparoscopic surgery to be able to see and use pathology to diagnose endometriosis definitively. And so there's a lot of referring out to individuals who are MIG surgeons, minimally invasive gynecologic surgeons, and those surgeons are very few and far between. And again, I'm speaking from experience in the United States, but a lot of what's in the literature in other countries as well across the world is that MIGS is a specialty within OBGYN that has to follow a fellowship, and it's extremely, it's relatively small in scope, and there's not a lot of surgeons who are MIG. So in order to find the patient or to meet the patient demand, the supply just isn't there. And another theme that the providers spoke in length about was the importance of multidisciplinary collaboration. As I mentioned, this disease presents often as unspecified abdominal pain and kind of goes from there. And so you have individuals in OBGYN, you have them in primary care, you have them in radiology, you have them in gastroenterology due to the symptoms that present for individuals with GI symptoms, which is quite common, and individuals with urinary symptoms. So if they're seeing a urologist, and so if there were some sort of specialty group of guidelines, how you should work up pelvic pain so that the individual who is going to you gets a shorter time from symptom onset. As I mentioned, it's about 7 to 10 years on average to when they get diagnosed and can get treatment, appropriate treatment. Something that a lot of these providers said is that it would be great to have everyone get on the same page so that these providers aren't running multiple tests and providing misdiagnosis, which is very common when you have a diagnosis of endometriosis. Our patient side of things, we switched gears and we looked at patients. We recruited patients all across the United States. Each individual patient had to have a surgical confirmation of endometriosis, which, like I mentioned, that excludes a lot of individuals who are, one, maybe asymptomatic and have endometriosis, or two, just haven't had the opportunity or the means to have surgery. Surgery is a cost prohibitive treatment option, and due to insurance and or other monetary and financial considerations, you might not be able to have surgery. So you might have endometriosis and it might be well suspected by your providers, by yourself, by specialties. But if you do not have means to have surgery, you don't have that diagnosis. So the individuals on the patient side who participated in our research all did have at least one surgery. Most of them had multiple surgeries. And a lot of the themes, again, all qualitative data was quoted and was coded and thematically analyzed by our study team. We had intercoder reliability to make sure that these codes were actually an accurate representation of what these individuals were saying during the course of their interviews. And so, as you can see here, some of the major themes included psychological impact, the financial impact, the lack of awareness and the need for self-advocacy, fertility concerns, and the major one that encompassed everything was quality of life. And some of these quotes really just kind of pinpoint just that public health burden that I talked about earlier in the presentation, and how the disease itself wreaks havoc on individuals' lives who have this disease, and what they go through in terms of the pain and the symptoms, but also trying to get a diagnosis and trying to get doctors to believe and understand what they're going through so that they can, if they're able to, access surgery to have some relief or other means necessary to treat the disease. And so with regard to some of these, quotes here, some of these things really just kind of resonated with throughout the course of the interviews. And these individuals who participated were all from very different backgrounds and socioeconomic, demographics and things like that. So it wasn't a clustering of all, it wasn't homogenous in that it was an all white upper class individuals who had endometriosis but had access to the best care. Some of the individuals who had I believe one individual had 12 surgeries, and fertility was her main concern. All she had ever wanted to do was get pregnant. Someone else, talked about the fact that they weren't able to have a job that, was able to accommodate their pain and their symptoms and their need for leave, because they needed the benefits so that they could access insurance and they could access things like surgery and physical therapy and things like that. And so it really kind of illuminated just exactly what individuals who have endometriosis go through on a daily basis in a very kind of short snapshot. And so just thinking about our results, what our research identified through the juxtaposition of the patient experience and the provider awareness was really the lack of awareness and misperception of the actual prevalence of the disease. If you remember going back to the slide from earlier, the endometriosis prevalence from the 53 providers across multiple different specialties, only 6 individuals, about 11%, got the actual prevalence correct. All other responses, the majority, 47 individuals, guessed one of the other choices. And so in thinking about that, the misperception of the actual prevalence of the disease is part of the problem when thinking about how to diagnose this disease, because if this was on individuals' primary care, OBGYN, GI, radio, this was on their differential when someone with unspecified abdominal pain came into a clinic or to a practice or to an emergency room, which often happens, and endometriosis was on the forefront of their diagnosis and their workup. It might get them to whomever they need to see in terms of specialty that much quicker. And I'm not saying that that's going to make the window from 7 to 10 years completely go down to 7 to 10 days. Maybe it goes down to 3 to 5 years, but that time makes a huge difference in someone who has this diseased life, because oftentimes this disease is misdiagnosed and it comes with a lot of other kind of gynecological, gastroenterology, and urinary symptoms, as I've mentioned. And then the difficulty of diagnosing endometriosis, the fact that there is no blood test or breath test or any sort of test or workup besides surgery that could allow for definitive diagnosis, because as I mentioned, surgery is cost prohibitive. Surgeons often don't want to do this surgery because if someone is presenting at 15, 16, 17 years old, surgery is not necessarily what you want to do first. You want to try other first line treatments. And so that's when individuals end up on hormonal birth control for the majority of their adult life after their first menses. And so thinking about science and technology and the lack of research and funding that goes into this disease that affects so many compared with some of these other diseases, we're trying to figure out how we can get that diagnosis more comprehensive and more compact. And then the insufficient treatment options and management tools, which really kind of plugs into that last one. The fact that hormonal birth control is first line treatment and surgery is really the second line of treatment. Once you can access that, if you're able to access that, you have a load of kind of missed opportunities in the middle there, and trying to figure out how individuals can work with providers, how scientists can work with the public, how we can serve to, how the individuals who have the disease can serve the individuals who are tasked with treating the disease, and meet in the middle and figure out what else we can do. Pelvic floor therapy is a wonderful option for individuals with endometriosis. It's often not prescribed or referred to by the OBGYN or the primary care physician because it's just not known about. I think in current time, a lot more celebrities and individuals with a public facing persona are speaking out about this disease. And so it's getting a lot more traction, but it still leads to, or begs the question of, what can we do for these individuals aside from raising awareness? How can we actually treat it more effectively, and how can we make it more accessible for individuals who need to have surgery to excise and not superficially remove the disease? So next steps, really what our research aimed to do was serve as a call to action for funding and research to improve patient outcomes. A lot of what our research unearthed is consistent with what is in the literature. There's not a ton in the literature, that said, and so we are looking for next steps for both students who are in training as well as clinicians in training, public health professionals, clinical professionals, so that we can have some sort of, whether it's a multidisciplinary workup across different, if it's brought down by ACOG, which is the American College of Gynecologic. I know in England there are different specialty groups that come together to create guidelines for endometriosis. I think it's similar in New Zealand, but there's really a lack of standard of care and standardization for this disease. And so we need to update those standards of care so that it is more consistent with what the patients are experiencing on their side. Supporting developments in research. Endometriosis is one of the least funded areas of research, again, especially in the United States. I think in other countries there have been some priorities and progress in recent years to get funding for this area of research, but women's health typically is a very underfunded area of research. And advocating for policy shift, allowing individuals who are in politics and can kind of mandate things to have a voice or a say at the table, so that individuals with endometriosis can kind of speak to their experience and what it does to their home life, what it does to their professional life, and things like that. And we wanted to kind of set a practical recommendation for the development of endometriosis and management tools moving forward. If there are any questions, please let me know. I did want to acknowledge the study participants as well as the Endometriosis Foundation of America, which is a nonprofit organization here in the United States. They're located in New York, and they do a lot with patients and researchers who are looking to move the dial forward with regard to this disease. And this disease was originally published in the Journal of Endometriosis and Pelvic Pain Disorders in February of 2020. And there's just a quote there from myself. I am myself an endometriosis patient, so I strive to educate and cultivate awareness about it on a daily basis because it is a debilitating disease and it really does affect so many. So there are my references. If there are any questions, my contact information is there. And I just, again, wanted to thank everyone for your time and